So on my computer, we have just flipped over to 7 o'clock now. So I'd like to say hello and a warm welcome to you all. It's great to see so many of you managed to join us tonight for this webinar on attention deficit hyperactivity disorder, or ADHD. That's probably the only time in my life I will ever use the term attention deficit hyperactivity disorder. It's a bit of a mouthful. So my name's Steve Bond. I'm a late diagnosed ADHDer and autistic with a sprinkling of other conditions. I've worked as a public contributor championing inclusive research and the benefits of community-led research. And I run a video production company called Autech, which provides employment for disabled filmmakers. I'm going to be putting your questions to Professor Samuele Cortese and Dr. Edoardo Ostinelli. Professor Sam Cortese is an NIHR, that's National Institute for Health and Care Research, Professor of Child and Adolescent Psychiatry at the University of Southampton, an honorary consultant for Hampshire and Isle of Wight Healthcare NHS Foundation Trust. Dr. Edoardo Ostinelli is an honorary consultant psychiatrist and senior researcher at the University of Oxford. A massive thank you to you all for the excellent questions you've already sent in and for the ones we're anticipating during the session tonight. We've had over 270 people register with more than 75 questions submitted in advance of tonight. If you want to ask a question during the event, please post it in the Q&A box. It's the little speech bubble at the bottom right of your screen. See that? Please highlight either Sam or Edoardo if you'd like me to specifically direct a question. We'll do our best to get through as many questions as we can, both asked tonight as well as those asked in advance, but I hope you'll understand we won't be able to answer everything in the hour we have. Also, unfortunately, we won't be able to answer any questions about individual cases. Please talk to a healthcare provider, a professional, if you have any concerns. Please also ensure that your camera and microphone are turned off. It's the buttons at the bottom of your screen. To change how the speakers appear, click the 3 buttons at the bottom of the screen next to the red phone icon, then change layout, and then select the sidebar or spotlight setting. Tonight is being recorded and you'll be sent a copy of the recording. This event has been organised by the National Institute for Health and Care Research, or the NIHR. The NIHR is a government-funded body that funds research in the NHS, public health and social care. If you're interested in learning more about research and to search for studies you can take part in, please visit the Be Part of Research website. Just search Be Part of Research. Remember, you can take part in many studies even if you don't have a health condition yourself. So that's all the intro parts out of the way. So let's move straight into the questions. I'm going to bag the first question for myself. So tonight we're going to be focusing on ADHD. But I would be interested to learn a bit about how researchers go about separating ADHD from, say, autism, or the 3 Ds, dyspraxia, dyslexia, and dyscalculia in their research.
Right, so I'm happy to take this first question, and I think it's actually a very good question to start our discussion because it's about the definition of the conditions that we are talking about. So basically, in medicine and in psychiatry and research, we call these diagnostic categories. So, you know, ADHD is diagnostic category, autism is another one, and so on and so forth. And there's been a long-standing discussion over the years as to whether we should lump or split these different conditions, because of course in the clinical practice as practitioners, a lot of individuals we see who come to our attention, they may come for ADHD, but they may also have other conditions, including the ones you mentioned, Steve. So the question is, should we all lump together or split them? In the current classification systems, which are called, for instance, the DSM, the Diagnostic Statistical Manual of Mental Conditions from the American Psychiatric Association, ADHD is grouped together with other conditions like autism and dyscalculia, specific learning disorders, and so on and so forth, in a big group which is called neurodevelopmental disorders, because they all share common features. However, current research has also highlighted the value in keeping these categories separate, because it is true that they have some some commonalities, but they also have specific characteristics in terms, for instance, of evolution over time, response to treatment, and so on and so forth. So I guess that research is still debating this, but there is a consensus that it still makes sense to keep them separate. So this is why we say, you may have ADHD comorbid with or associated with another condition, and oftentimes this is the case. But calling them simply neurodevelopmental conditions does not provide us with the level of detail that we need to better, support these individuals.
Thank you for that, Sam. Edoardo, did you want to add anything before we move on?
No, I mean, I would agree entirely with Samuele. I mean, it is very important to try our best to capture the challenges, the specific challenges that each individual may be facing. So I appreciate and understand this macro category called neurodevelopmental condition, but providing additional details definitely is helpful.
Super. Thank you very much for that. So on to my next question. What is the brain basis for ADHD? And is there any new research on biomarkers and genetic testing? Biomarkers are signs in the body that may help diagnose or understand a condition.
So I'm happy to answer, Samuele, if you want, you can chip in. But ADHD has been linked to differences in brain structures and function, especially in some areas, like areas responsible for attention, impulse control, and executive function, which includes, for instance, skills like planning and decision-making. And we have research that shows that people with ADHD tend to have or might have reduced activity in one area of the brain called the prefrontal cortex, which is a brain region that helps regulate behavior, but also differences in the dopamine system, which may affect motivation and reward processing. Now, we have recent studies coming out from research that have explored potential biomarkers, either brain imaging, so looking at how different brain regions actually are connected, how they work together, but also looking at genetic factors, because we know, and we see this very often, ADHD tends to run in families. Now, there are some genes that have been identified, and these may be in the future promising candidate, but right now there is no single biomarker, gene, or test that can diagnose ADHD. The consensus is more that like the most cases of ADHD are caused by a combined effect of many factors, genetic, but also environmental, each one contributing with a small effect.
Yeah, I agree with Edoardo. Everything he said is very important, and it reflects what research has shown. I think also I wanted to add simply that, when we look at these studies, for instance, studies of brain imaging, where we try to take pictures of the brain or to see how the brain works or how the structure of the brain is. And when we read studies like, comparing a group of individuals with ADHD and a group of controls, so individuals without ADHD, and the study concludes, the prefrontal area of the brain work less well or is smaller, it's important to appreciate that these are average differences at the group level, which means that if we look at the individual level, we may not find that particular difference. In other terms, there is not such a thing as the ADHD brain, but there are different ADHD brains because there is a variability at the individual level. So this is why, for instance, we cannot use brain imaging techniques like MRI to diagnose ADHD. So these are really differences that are appreciated in research. And so we need to understand better the specific differences in that particular individual. historically, I think when research on the brain started in ADHD, and we are talking about basically the 80s, the 90s, probably researchers were retrospectively a bit naive, because the question was, can we find the area or the few areas in the brain which are abnormal? Now we know that it's not just a matter of individual areas, but it has more to do with alteration in how different networks of the brain are connected. So this is really more complex than say, your area in this particular area, the brain is different. So it's much more complex. And so this is why we have not found yet any biomarker, any marker that may differentiate and may allow us to diagnose these individuals, because basically the underlying alterations are very complex and variable.
Super, thank you both for that. That was enlightening. For myself, having gone through 63 years of my life without even having heard the term executive functioning, I think to me that's the bit that is perhaps the least well understood. You get the attention bit, you get the hyperactivity bit, but the executive functioning bit is like a wow moment, was a wow moment for me. So thank you for highlighting that. Let me move on to the next question. ADHD appears to be a modern phenomenon. Is this a disorder that was not recognized years ago, or is it an increasing problem? Who'd like to take that one?
I mean, I'm happy. We can do still the double act, but I mean, we speak very often, Samuele and I, on this topic. ADHD is not a modern condition. It's more like our understanding and our recognition, thanks to research that has evolved over time, and now is much better. Still has to improve, but is much better compared to the historical records. But we have evidence that ADHD has been observed for at least like 2 centuries. Of course, they were not using the term ADHD, but the syndrome, if you want, something similar, a collection of signs and symptoms, was first described in 1775 by a German physician, and it links quite well with the modern observations, if you want. So the debate, I think, whether ADHD in terms of diagnosis has been increasing, is increasing right now, or whether it has always been diagnosed, I think is very actual. You can find it at least once a week in every newspaper. I think that we do have research that suggests that the prevalence of ADHD in the general population is quite stable. It is around 5% in school-aged children and 2.5% in adults. What we have is an increasing new diagnosis, potentially thanks to increased awareness, both in the general population, but also better training and more awareness in on the clinician side, that have contributed probably to this rise of ADHD conditions. Now, this is something, of course, that we need to track over time, and we will need to see how it goes in the next 5 to 10 years. But ADHD is not something new. Samuele, I don't know if you want to.
Absolutely. I think the key message is not new at all. We have descriptions, as you mentioned, in the literature, in classic literature, but the very first scientific description of ADHD, or actually of children nowadays we will label as ADHD, was interestingly provided by George Steele, a pediatrician in the UK, in a paper in The Lancet, which is a very famous medical journal, in 1902. And so when we hear that it's a phenomenon from America, actually the very first scientific description was provided by an English doctor. It's very interesting to see that then there's been a change in the conceptualization of this condition, but children with those problems have always been there.
Super, thanks both. Just a quick follow-up from through history, are there any famous ADHDers like we have, Einstein or Mozart as autistic people?
Yeah, I mean, I'm always quite hesitant in providing this information because, to make a diagnosis, we need information. So it's difficult to ascertain as to whether these individuals, they met the criteria based on the information. So I'm always kind of skeptical, but certainly, you know, there are examples of important and famous people who have declared a diagnosis of ADHD, and certainly I think this also highlights one of the themes that was in one of the questions related to the positive aspects of ADHD. We may want to discuss this later on, perhaps, still, yeah.
Super. All right, thanks. I did love, Edoardo, your comment. The research gives us this understanding. So the expert comes from accumulative research over the years, and I think that's the real focus for today, is that where this understanding comes from is from research. So thank you for that. Next question, and we've had several questions about ADHD in women. Are you aware of any research being done into how ADHD affects menopause? And more generally, can you discuss the link between female sex hormones and ADHD symptoms? Who'd like to take that one?
If you want, I can start. Samuele, you can.
Yes.
Oh, sorry. You go.
Oh, no, go ahead, Edoardo.
I was just about to say that, I mean, it is a growing field of research. It is something that I think increasingly we are focusing on. Probably we should have started sooner, but sooner than not doing research at all. But there is a growing research looking at the overlapping, if you want, of ADHD symptoms and challenges associated with ADHD and change with hormonal fluctuations, especially during premenopause and menopause, which inevitably they are associated with these hormonal fluctuations. Because we know that estrogen, one of the biggest key players, let's say, is an hormone that can influence several neurotransmitters, not only dopamine, but it can have an impact, may play a role on ADHD symptoms. Now, it's very difficult to say whether it is an overlap that can simply increase the challenges, whether there is really an interplay, meaning that during these phases, the functionality of dopamine and these neurotransmitter, if you want, networks is affected, but we see clinically this interplay in these two different conditions. And I think that we are becoming increasingly aware of the unique challenges that women with ADHD may face during these phases in general, but especially during these phases. I don't know if you want to add.
I agree, Edoardo, and I think it's extremely fascinating topic. And as you said, we know really we don't know a lot yet. I have been attending conferences on ADHD for the past 20 years, and I think usually there were no really sessions on this topic. Now we start seeing this. Any conference has already at least one session on this interesting topic, but we need more research. Research is ongoing. There are many research groups around the world, in particular colleagues from the Netherlands. They're doing a lot of research on this, the United States. So we need really to understand better how menopause and hormonal factors influences ADHD and vice versa. And what is particularly interesting to me is also to understand better how hormonal factors may influence the response to medication, for instance. Mm-hmm. Very fascinating topic, but we don't know a lot yet. But certainly we will have more information in the upcoming years. So it's something that definitely is a focus of research, intense research right now.
Super, thank you both. So this segues really nicely into the next question, but I'd like just to keep bearing in mind as we go through the questions whether there are any differences, male and female, in terms of presentation drugs or whatever, because now we've kind of opened that door. It's good not to close it again. So the question is quite a simple one. What have been the most effective treatment options for ADHD, and what research has been done to evidence this?
So we completed actually very recently an NIHR funded project with Samuele in which we specifically wanted to look exactly at this question. So we took all the available evidence on any kind of intervention, meaning medications, but also talking therapies, and if you want, neurostimulatory interventions like transcranial direct current stimulation. So very, very different kind of interventions. And we wanted to look at the performance of these interventions in adults with ADHD. And we looked at several outcomes. Mainly, we're focused on the core symptoms of ADHD, like the lack of focus, but also hyperactivity and impulsivity. And what we found in a nutshell, because it was a lot of outcomes and a lot of findings actually, is that stimulants, namely methylphenidate, dexamphetamine, lisdexamfetamine, and non-stimulants like atomoxetine were the treatments better supported by the available evidence at 12 weeks if we focused only on the symptoms. However, when we looked also at what we call acceptability, which means whether people after time were still taking the treatment, stimulants had an advantage over atomoxetine. So this is the best available evidence. There were a lot of other interesting, if you want, findings. I would just name one that is about the talking therapies, because what I described you was when we looked at both narratives. So the point of view of people with ADHD telling in all the studies how actually they were feeling, but also the clinician point of view, looking at whether people were improving. Now, when we separated the two and looked only at one of the two separately, what we observed is that there are some treatments that may be effective, may be helpful, like CBT, cognitive behavioral therapy, a very common talking therapy, psychoeducation, mindfulness, and many others. So we noticed the mismatch in what may be helpful from the clinician point of view and from the patient point of view, which is something that definitely will need to be further addressed in future research. And again, I would just like to reiterate what Samuele said for another question at the very beginning. These are all average effects. So it does not mean that stimulants work and other medications that I have not named, they do not work. This is about an average effect if you take 1,000 or 2,000 or 3,000 people with ADHD. At an individual level, of course, you will have some people that find maybe another kind of treatment, like physical exercise, also helpful. I don't know if Samuele, would you like to add?
Yeah, I just wanted to highlight once again that this that Edoardo described, which is a research published by Edoardo as the first author in the Lancet Psychiatry this year, is the most comprehensive and rigorous synthesis of all the evidence on treatments in adults with ADHD based on trials, randomized controlled trials. So I think this is important because when you look for evidence on specific treatments and you Google this, you may get easily lost. A lot of information, sometimes mixed information, so you may really get easily lost. So it's always good in this case to take the best evidence synthesis available out there. And this one, published by Edoardo, is open access. So if you write Edoardo's name in Google and Lancet Psychiatry or ADHD, you will find easily this study. It's a very technical one, quite complex, but we have done a lot of dissemination in this study funded by the NIHR, where we have translated in simple terms the findings. So hopefully you may find this helpful as well. And I say that this study highlights many results from trials, but these findings need to be complemented by the results of other studies that are use a different design. So they are not trials, but there are studies conducted in the general population, because from those you have a lot of additional information. For instance, we have shown that ADHD medication in adults reduce the risk of mortality, for instance, which is a very important finding.
Mm-hmm.
So we really need to complement this with additional information.
Super, thanks both for that. I thought it was fascinating that you distinguish between the clinician's view and the acceptability view from the patient's. And I, as a patient, that to me is a really important to make sure that that we're researching that as well as almost like the pure science of improving symptoms and things. So thank you for that. Next question then. We've had several questions about getting a diagnosis. Are you aware of any changes or research that will help speed up the assessment and treatment process?
I mean, again, as we start, and Samuele can chip in, there is a lot of research going on, I think, especially about artificial intelligence, inevitably. It's something that is revolutionizing healthcare, and it is definitely revolutionizing research healthcare as well. And there are a lot of studies that are trying to explore whether artificial intelligence could help. What we usually tend to think right now, 2025, is whether artificial intelligence may help, may support the diagnostic process rather than making a diagnosis. Making a diagnosis is very complex, it's very difficult, and it is never a fact of like an answer to one question or one specific test. We're quite far away, unfortunately, probably from that, because it is quite complex. Mental health and ADHD is very complex. So hopefully in the upcoming years we will have more tools. There are some that are being launched as we speak, and some have been launched in the recent years. But right now, I would say they're not really part of the routine clinical care. It is something that probably we will start seeing in the upcoming years. Samuele, do you have a view on this?
No, I think this is a very important question, of course, and I guess that the issue, so to speak, is that as with any other condition we see in mental health services, ADHD diagnosis is based on a subjective evaluation. So there is no test, an objective test, as we say. So inevitably, this may cause problems because we may have conflicting information, I don't know, from parents, from teachers, or from other adults. So what do we do in these cases? So this is why the process, the diagnostic process, may get somehow challenging. So over the years, there's been a lot of research in trying to find a solution, as Edoardo said, to support rather than replace the clinical assessment. Some of you may have read about the QB test, which is a particular test combining some neuropsychological tasks, so tasks that you do on a computer, and also an infrared camera that measures the movement. And some of you may have seen that NICE, the National Institute of Healthcare and Excellence, recommended last October, I think it was, the QB test as an optional tool to support the diagnostic process. This is very important to highlight because it was not recommended as a tool to replace the clinical assessment. It's just a tool that can be used to speed up the process. Actually, the evidence we have from available studies is that the QB test may speed up by 15% the time to diagnosis and may make the clinician more confident in ruling out conditions that are not ADHD. All in all, I think that the diagnosis is still clinical, but we do have some tools to support this process. And artificial intelligence, as Edoardo said, may eventually provide additional support in the future. But once again, currently, the diagnosis is based on gathering information from several settings and interviewing the person and the people who know the person, and getting additional corroborative information.
Fantastic, thank you both. We can't talk about waiting lists and things like that, but what would you say on average is the assessment time for somebody for an ADHD assessment in hours or clinical time to get there?
It depends, of course, across the countries, but there are areas where it's up to 2, 3, 4, 5 years. Which of course is very challenging, and we do understand, we appreciate this is far from being ideal, optimal. So there is all a discussion currently how to tackle this massive issue of the waiting list, and there are also ongoing studies actually expressly specifically on that. For instance, I'm a co-investigator in a NIHR funded trial led by Professor Samuele at King's College, which is called Optima, and is about testing a digital online behavior interventions for parents of children who are on the waiting list for an ADHD assessment. So we need to provide support to individuals while they are on the waiting list.
Absolutely. But once you've got through the waiting list, how long is somebody going to be spending with a clinician?
It depends, once again, is variable. Actually, the diagnosis of ADHD, everybody says is a challenging one. I don't think it's more challenging than any other diagnosis, any other condition. And the problem is that in some services, there are pathways. So, you need to go in a pathway, you get the diagnosis, then you need to wait again another year to get the treatment. And then if you want a diagnosis of an associated condition, you go to another pathway, and this takes time. So it's really not ideal at all.
Thank you, Sam. Appreciate that. Let's go move to the next question then. So this is from the chat. What does the current research say about the relationship between early trauma, executive dysfunction, and ADHD?
Would you like, Edoardo?
Yeah, I just wanted to emphasize that, clinically, but also there is research on early trauma in the context of ADHD, but also, of course, per se, because there is the potential that early trauma may be, in a way, look like ADHD. So it is, again, understanding whether what we are looking is somebody that unfortunately has had early trauma and ADHD, and these may be completely unrelated. Of course, they will add in terms of challenges and burden, of course, inevitably, whether it is only, for instance, early trauma, and it looks very much like ADHD, and this, in a way, there is some initial research that says that can try to explain why it looks so much, because dopamine is or may be affected by early trauma, and also some areas like the amygdala, but also the prefrontal cortex, what we named before, may be affected by early trauma. So it makes sense that you could end up with a similar picture, but we are still exploring, like research is still exploring whether there is a clear connection between the two. Probably is very complex, and again, it changes a lot in terms of individual experience from individual to individual.
Yeah, I agree, Edoardo, and I think to summarize, we could state that until probably 10, 15 years ago, the issue was, is it trauma or is it ADHD? Now we start appreciating that maybe it may be trauma and ADHD. So they're not mutually exclusive. Of course, for those who have complex and difficult experiences in terms of trauma, maltreatment, the standard treatment for ADHD is not enough. We need to provide additional support and therapy. But certainly, you may consider a treatment for ADHD in the context of trauma. Also because the reason has always been trauma may cause or may look like ADHD, but now we also know that individuals with ADHD are more at risk of traumatic experiences. So they are interesting interaction. And, we do have emerging research in the field. For instance, you may remember the adoptee from the Romanian adoptee from the Ceausescu regime. And they have been followed up over the years, and some of them developed a characteristic very similar to an ADHD presentation. So we know that extreme deprivation can cause symptoms which look like ADHD.
Fascinating. Thank you. From some of my lived experience, I've certainly seen undiagnosed ADHD leading to trauma, particularly in educational settings. And then obviously when the diagnosis happens, you've got the whole pot to deal with at that particular point. Thank you both for that. Let's move on to the next question. And we've had a couple of questions about dopamine deficiency. Can you explain what this is and to what degree the dopamine deficit hypothesis, oh my goodness, of ADHD is supported by current research into the underlying mechanisms of ADHD?
Fascinating question. I will try my best to explain in using like avoiding any jargon, but the dopamine deficit hypothesis is an hypothesis, of course, that suggests that ADHD may be caused by lower dopamine activity, so lower activity of this neurotransmitter in our brain, and specifically in some, like in certain brain regions. It's not like overall across the brain. And specifically, we're speaking about those brain areas that may be involved with motivation, attention, and reward processing, which in a way translate quite, of course, beautifully, if you want, with what we see in terms of challenges of the people with ADHD may be facing. Now, dopamine is a neurotransmitter and has been, in a way, linked to motivation and focus historically. And also we have what we call preclinical research, which is quite interesting. So it's not only research done in humans, if you want, but we have historically preclinical research that in a way links dopamine with a reduction in attention, but also a poor impulse control, and also the tendency to seek immediate rewards. So there is this difficulty in the delay of the gratification aspect. Now, research is fairly confident that dopamine, in a way or the other, is involved in ADHD. A lot of the interventions that we have, they clearly target dopamine, and they are effective. So dopamine is part of the picture. What we are seeing from research in the last 10 to 15 years, I would say, is that it's not only dopamine. It's not only dopamine in terms of like, it's not a dopamine dysfunction. It's not a dopamine deficiency per se, full stop, but it's something more. Dopamine is implied, is one of the actors, and maybe we will discover that it is one of the key actors and play this role, but there are the differences in brain connectivity, what Samuele mentioned before, that is how some areas of the brain actually communicate between one and the other. And further research in the future may, of course, contribute a lot in giving us a better understanding of the full picture.
Yeah. Absolutely, and I think as a take-home message, I would like to stress that certainly dopamine is involved in the pathophysiology of ADHD, in the cause, but is not the only aspect. So research tells us clearly that when it comes to complex phenomena like the brain phenomena we are describing, we need to avoid a simple, simplistic explanation. So stating ADHD is caused by a deficit in dopamine does not reflect the complexity. Certainly, dopamine plays a role. The stimulant medication, methylphenidate, amphetamine, they increase the level of dopamine. And actually, a lot of research on dopamine was developed based on the action of this medication in ADHD. But certainly, there are also other avenues, and these are being explored currently in research in terms of developing new treatments.
Super, thank you both. To the best of my knowledge, I've never had my dopamine levels tested. Is that standard practice, or Is it difficult to do?
Well, I would say it is not standard practice. It is, if you want, something that in research is done in some studies. We want to know via imaging and some specific imaging techniques how some areas of the brain, we say, flare up, meaning that they actually are active in certain situations, and how much dopamine in a way is active in that area, but it is not part of the routine clinical consultation. And we will not use it, I think, nowadays, at least, to make a diagnosis.
Super, thanks. I was just assuming it might be a blood test, but it clearly isn't.
Not something you can measure in the blood test with a blood sample, and as we said, there are no biomarkers, so including any biochemical substance, we don't use this for the diagnosis.
Super, thanks. Let me get the next question. This is from the chat, and I must apologize that I don't have the name of the people who put it in the chat, so that's why I'm not giving your name. But the question is, what can we do to support children who have low impulse control, especially around dangerous behavior? Does research findings indicate interventions which help these young people?
I don't know if Samuele, would you like to take this, given your experience in child adolescent psychiatry?
Sure. Well, actually, we know that the problem in controlling impulse and impulsive reaction is part of ADHD in many individuals. Not in everyone, because there are those who struggle mainly with problems of attention and concentration, but in many individuals, control of impulsive reaction is challenging. Now, certainly when it comes to the possible management strategies, how can we support these children and their families? As always, we have two types of possible interventions: the pharmacological ones and the non-pharmacological ones. And ideally, we want to use a, as we say, multimodal, so combined approach, which combines pharmacological and non-pharmacological approaches. So in terms of medications, there is quite solid evidence that these medications, especially the so-called stimulants, work quite well, not only for attention and concentration, but also for hyperactivity and impulsivity, impulse control. And something which is quite related to this, which is emotional dysregulation. However, we also know that medications are not enough, and so they need to be combined with non-pharmacological approaches. So in children and young people, we have basically behavioral interventions that are directed either to parents or in case of adolescents, to the adolescent themselves. So behavioral intervention, parent training, or CBT, cognitive behavioral therapies. We have also, when the issue is more around physical aggressiveness in terms of impulse control, other strategies like nonviolent resistance and VR and other approaches that are well studied and supported by evidence. While other approaches like dietary interventions, neurofeedback, cognitive training don't seem to be effective in this regard. One last aspect I would like to highlight when it comes to a child who struggles with impulse control, we need to understand any reason that may lead to this. Maybe ADHD, maybe also due to associated conditions. For instance, we know that up to 70% of these children struggle with sleep problems, and certainly sleep deprivation is related to problems with impulse during the day. And in this regard as well, we are making progress. We have currently ongoing, actually we are going to start next month the recruitment for a large trial which is called the DISCA trial, which is once again a trial funded by the NIHR, which I co-lead with Professor Cathy Hill in Southampton, who is the lead of the study. And here the aim is to develop a behavioral intervention tackling sleep primarily in children with ADHD, but we will test also the impact of this intervention on sleep on other aspects during the daytime.
Super, thanks for that. Just a quick question, Sam. You've talked about behavioral medication. Is there anything about environmental, creating an environment that is more supportive for the ADHD child?
Yes, certainly. So when I actually refer to behavior, it's also around, thinking how to structure the environment. And certainly we need to understand better not only the psychological environment, but also the physical environment.
Yeah, thank you. I think you might have just frozen on me, Sam, so I'm going to go to the next question. Another one from the chat. Here we go. Do you know what the longest longitudinal study is that looks at ADHD outcomes or treatments? Edoardo.
So I think it is really important when we speak about. Oh, sorry. I think it was someone from the past. Just hearing now. I think it is very important to differentiate when we speak about studies, whether we're looking at randomized control studies, for instance, and observational studies. Like randomized control studies, the longest, usually the long studies, they tend to be up to 52 weeks, so around the year mark, because they're very expensive and you need a lot of resources in terms of money, in terms of course, staff. When we look at longitudinal studies, we have several examples actually of studies that started observing children and then follow them up throughout life. Now, these studies, they are very useful for us, and this I think mirrors quite well with what Samuele said. It's not looking only at one study, but we need to collect and look at all available evidence, also from different types of studies, because they allow us to look at challenges over time in terms of how challenges in adolescence and in childhood translates then into maybe challenges in the workplace or when at university, and then also later on in life. I mean, one example that comes to my mind is the Dunedin study in New Zealand. I think it started around the 70s, and it collected a wealth of data throughout years and years and decades, not specifically about ADHD, including, of course, information about ADHD, but also other kind of physical and mental health conditions. I don't know if Samuele, do you remember any study going on longer than that one?
I mean, I think the longest follow-up study in the entire world is the New York University study. This is a 33-year follow-up of children who were diagnosed with ADHD or equivalent of ADHD in the 70s, and then they got funding to follow them up for more than 30 years. So that is certainly a very important study that showed that basically ADHD is associated with a number of negative outcomes if not treated properly in childhood and also in adulthood.
Super, thank you for that. I mean, I agree with the person in the chat with the question. I think if you could put in a link in the chat or follow up with it, that would be really fascinating to look at something that's gone through life cycles like that. Thank you both for that. Next question from the chat again. This is brilliant. Is there significant overdiagnosis in autism and ADHD?
Well, I mean, I will start speak about autism and ADHD, and then we can tackle the overdiagnosis aspect. So ADHD and autism frequently presents together. So people can have only ADHD and people, of course, can have only autism, but it's not uncommon in terms of like comorbidity. So having both, as much as other mental health conditions that we are aware that may be present in combination with ADHD. Now, whether there is an overdiagnosis, it is very difficult to assess. The research studies that have been done so far in the last 5 to 10 years, there was also one study in the Lancet Psychiatry, tell us that the prevalence of ADHD in the general population throughout decades is somehow stable. which means that when we take randomly some people from the general population and we test them with a thoroughly diagnostic process that we discussed before, is very complex, and I mean, not more complex than the standard mental health, but it's not a couple of questions in 5 minutes, definitely. We observe that actually these rates are actually quite stable. The point is, now we know more about ADHD. There is hopefully less stigma. People are more aware of the challenges and how ADHD may present. Also how ADHD may present later on in the adult life, which may be different compared to how it presents in childhood, for instance. And also, for instance, the differences between males and females, how it tends to present in female, which again may be quite different. So we think that this increase in the awareness may be explaining why we have a boost in new diagnoses in the last years. Yes, but I will not call it overdiagnosis. I think again it is probably oversimplifying something that is more like a shift in the interplay within, like between the society and mental health. It's quite complex, and we will need time to disentangle this complex situation. I don't know, Samuele.
Yes, I think you are right in the sense that if we look at the prevalence of ADHD in the general population using solid methods to diagnose ADHD, roughly we can say that 5% of school-age children present with ADHD according to good assessment, and roughly 2.5% of adults present with ADHD. Now, we are here every day. We hear, ADHD. We read on the newspaper, on the media. So we tend to think, everybody has ADHD or autism right now. The problem is that there is, as Edoardo said, more awareness. So it's just the top of the iceberg that we are looking at. So if the prevalence is 5% of children, probably only 1% will get a diagnosis and the treatment. So there's still a lot to do. That doesn't mean that there is no overdiagnosis in some area, to better say misdiagnosis, which means that, some who don't have ADHD, probably they will receive a diagnosis of ADHD. But we said that the majority of those who have ADHD are not diagnosed yet and not treated yet properly. This is the point.
Super. Thank you for that. We're sort of coming towards the end of it now. We have a couple more questions coming up. I'm just going to give you a warning that we're going to close with just some final remarks from you both about the future of research in the topic of ADHD. So if you could just make sure you're prepared for that final question or summary. So the next question here is, how common are, oh my goodness, circadian rhythm sleep disorders in ADHD? And what is their impact? What role can other health conditions play?
I mean, circadian rhythm disorders speaks about, if you want, the sleep-wake cycle, which is something that is fundamental for all of us, for all actually forms of life. And disruptions, issues, challenges in this sleep-wake cycle can be common in ADHD, definitely. They can be common both in childhood and adolescence, but also in adulthood. A lot of individuals with ADHD may struggle with difficulties falling asleep, waking up late, and especially maintaining like a constant sleep schedule. We have heard before from Samuele about interesting research that is going on as we speak on sleep in the context of ADHD. I don't know, Samuele, if you would like to add something on that specific study, given that you are involved.
Yeah. So first of all, circadian rhythm disorder is part of sleep disorder. So I think that there is awareness now that sleep is fundamental, and actually the NIHR itself acknowledged this when they decided to fund our trial, the DISCA trial on sleep and the treatment of sleep disorders in children with ADHD, specifically insomnia. The question was also more specifically on circadian rhythm disorders, so an alteration, a shift in the rhythm, and this is quite common in children, young adults, and adults with ADHD. They would say, you know, I struggle falling asleep earlier, I cannot wake up early in the morning, so there is a change in the rhythm. And we know that there are many factors related to this, poor sleep hygiene or behavioral issues, but also more neurobiological alterations. There is all a line of research, for instance, on alteration in melatonin, which is a substance which allows us to fall asleep. So melatonin may be helpful in these cases alongside behavioral sleep intervention. So it's definitely an area that has been the focus of a lot of research, mainly I think for three reasons. So first is that sleep problems may have an impact on ADHD, may worsen ADHD symptoms. If you think yourself, if you don't sleep well, your attention will not be good. Secondly, sleep problems are a huge problem which impacts the quality of life of the individual and their families. And third is that sleep problems may mimic ADHD. So sometimes, individual with a sleep problem, which require a specific treatment in terms of sleep problem, may look like those with ADHD in terms of the problems, the symptoms they manifest, but we should not treat this as ADHD. We should consider this as a sleep problem. So it's what we call in medicine the differential diagnosis issue. So definitely there is a huge amount of research on this, a very fascinating area.
Super, thanks both. So I'm going to just move to the sort of closing up question now. Which is a shame because we've covered sleep and medication and treatments and stuff. We've not covered food and diet advice. So if you want to blend that into your final summary answer, that would be great. But the question really is, so where have we got to in research and where are we going? Just give us a quick summary, sort of 30-second summary in your minds of where we're at the moment in terms of researching ADHD.
Well, from my point of view, we are in quite a good position and potentially a transformative time. Future research in the upcoming years may be really helpful in having a direct impact. So rather than finding something that is very useful from a theoretical point of view, actually having a real impact on the clinical care. One area which I'm sure that in the upcoming years we will have something unique is what we call precision medicine, meaning that we hopefully will be able to target based on some characteristics one specific treatment and associate this with one individual, rather than trying a treatment, see how it goes, and then if it doesn't work, try another one. There are areas in medicine that are definitely more advanced. I'm thinking about cancer and all the inflammatory conditions. Mental health is a little bit behind, but we are going there, and this is a very interesting direction of travel.
Thank you, Edoardo. I totally agree. The idea of titration and trialing different things and seeing which works is a very painful process for the recipient. Sam, do you want to add your final thoughts?
Yeah, no, I would have chosen actually as well the topic of precision medicine, so targeting the treatment to specific individuals. Actually, I was funded by the NIHR, once again, what is called an NIHR research professorship to develop this topic. So hopefully there will be more developments in the future. The other area I think that is important and is clearly emerging, I think, a completely different topic is around the neurodiversity movement. So neurodiversity movement was not born as a clinical entity. It was born as a social justice movement to acknowledge, the rights of these individuals. And so there is the movement is highlighting also possible positive effect and the value of diversity within these individuals. So to me, what will be important in future research is to understand better how the neurodiversity movement can inform and have a dialogue with clinicians, because we are talking about two different worlds, so neurodiversity movement and the clinical realm. And it's important, it will be important to understand really what are the implications of this movement in terms of the clinical management, the service organization, and the treatment of these individuals.
Fantastic, Sam. That gives me great hope for the future, because I think that is really important. The social movement and the clinical movements get together, and absolutely. So thank you for that. So just some closing remarks finally in the last 30 seconds. I just want to thank you, Sam and Edoardo, and for everyone for providing the questions. And I hope you found it an insightful and informative session. And I think that we've got enough questions for 2 or 3 more of these sessions. And so let's make some noise about that. Thank you also to our hosts at the National Institute for Health and Care Research. And if you want to learn more about research and how you can take part in studies, even if you're healthy, then search for Be Part of the Research website, which I'm sure we put in the chat as well. Everyone will be sent a recording of tonight's event as well as an evaluation form. Please do take a moment to complete it. I thought it said please don't take a month to complete it, but do it now is probably your best bet. We want to run more of these events, so we want to know what we're getting right and what could be improved. So it just remains me to thank you all once again, and hope you have a very pleasant evening.